It is official time, iPhone time. It is 12:01. So let's get started. Okay. Well, welcome to UW TelePain. We're gonna once we get ourselves. Oh yeah, I do need
Sorry about that, guys.
I've been running all around the country doing all sorts of what I think important pain stuff. I hope it turns out to be important pain stuff. So I've missed a couple of sessions. So I'm going to reorient. And I was just talking with Dr. Robinson, who is co-editing a Rehab Clinics of North America volume, I guess it's called. Issue that's going to be out on this subject. So I may actually correct myself because that's more up to date even than my current slide set here. So I'll be speaking today on non-opioids in chronic pain management from a clinician's perspective, which is who we are and who are hopefully going to be benefiting from participation with UW TelePain. And then we have two cases, and I see Gwen or Gabby Lucas on the screen. Nice connection. So you'll be up first, and then Kimberly.
Pickle? I'm not sure how to pronounce it.
Pickell at Madigan is going to be doing a second case, and we'll collect that data. So we should have time as well for lively discussion. So let me just get started. So non-opioid clinical pharmacology and chronic pain management. Because this is a CMA activity, I have no disclosures. I should say that I will be speaking off-label because much of what we use for pain management in the non-opioid category that is, in my view, of value is off-label. And frankly, much of pain treatment best practice in general has limited or actually absent randomized controlled trial quality data. So we're going to be speaking as much from clinical consensus as many of our patients have the experience of care delivered at that level. I've got three key objectives. First is to understand why chronic pain therapy should not be opioid monotherapy. So I'm going to start with the negative, that opioid monotherapy is not optimal pain care. So if not opioids, what then? Objective one. Number two, understand the clinical value and potential side effects of three broad categories of medication. We're going to focus on anti-inflammatories, tricyclic, and I will mention other antidepressant category drugs, so broadly antidepressant drugs, and the anti-epileptic drug category or the anticonvulsants, depending on which literature you read. And I'm referring to here as AEDs. And then finally know the role and value of these drug options. So introduce as much clinical evidence as is available currently for improvement in our patients' outcomes. So very briefly, by introduction, why non-opioids? And basically, I'll speak to the fact that evidence-based recommendations simply state that. The American Board of Pain Medicine, position paper 2009, American Pain Society endorses this. And currently, maybe this is different than probably 10 years ago, I have not been to a conference of experts where there's any disagreement on this currently. That they are simply not anesthetics. You can use an opioid at an anesthetic dose, and that's done in the operating room with an intubated patient with no consideration of function. In terms of effectiveness studies, acute pain is different than chronic pain. And I want to really make an important point here that opioids in the management of acute pain is still appropriately first-line therapy for moderately severe pain or injury. So we're going to be talking about non-acute settings, or in other words, chronic non-cancer pain care. I'm not speaking either of palliative care, so I'm going to exclude that as well. So the focus is going to be on chronic pain. And if you look at the effectiveness data, the American Board of Pain Medicine, in their review, discusses this. Old review from Dr. Jane Ballantyne and Jinron Mao, working with her 2003, describe a very nice review there. And I will link the reference to update. There is a link right now. It's 2 months old. It's actually one of our faculty, Dr. Judith Turner and Roger Chu from Oregon Health Science University, plus others did a large evidence-based review for National Institutes of Health and basically described one circumstance that met low to moderate quality of evidence in the fact that if you give someone a fentanyl lollipop and they're on a chronic opioid, that they will have 2 hours of reported improved analgesia, which I think is useless as a clinician, and for chronic non-cancer pain is not only unapproved, but is not REMS compliant. So frankly, there is no quality evidence to support the use of opioids, and particularly at high dose. And the risks of accidental overdoses, ninefold with high morphine equivalent dose, published 2010, fall, sleep disorders, hypogonadism, obstructive sleep apnea, etc., diversion, addiction. It's a mess managing, and so if we could pick non-opioids, we'll do a whole lot better. So if we look at the menu of options for treating chronic non-cancer pain, and we strike opioids out, I just said, let's talk about everything else. I don't have time in my limited presentation today to go through all these, but I really want to identify that we have many other strategies. So the answer to the question, if not opioids, what then? There's a list, and it's not even complete. We'll speak a little bit about hypnotics and sedatives as to why we really don't want to be using them. I mentioned antidepressants, antiepileptics, and NSAIDs. We'll talk briefly on anti-spasm drugs. A mere mention on cannabinoids, and I know that's always a hot topic in conversations, particularly Washington State and Colorado. Welcome, Fort Carson, for joining us. And I guess Oregon now is in the same stew as us in terms of interpreting this. Certainly the role of interventional procedures for diagnostic and short-term relief, but that does not meet the test of chronic long-term management strategies. Multiple behavioral therapies, multiple physical activation therapies and other strategies delivered by our colleague physical therapists and occupational therapists, and complementary and alternative medicine techniques, which have about as robust an evidence base as we have for opioids. So bottom line is we do have lots of options. Bottom line, it's patient self-management that we want to get to in all these techniques. And if we're prescribing drugs, they're managing on our drugs, not on their own intrinsic systems that can improve their pain. So first word, sleep management. That's on our pain tracker. It comes up as a key item. It is the first thing I target in my management of my patients with chronic pain. It's the first thing I teach my medical trainees, students, residents, and fellows, that if you can get the patient sleeping, you will have an immediate improvement in their quality of life, and you will start to see a decline in pain scores. There is evidence that if you improve sleep quality this is not in chronic pain setting, but we have to extrapolate here, in experimental non-chronic pain patients. So these are normal people in experimental circumstance. You sleep deprive them, and then you return them back to sleep. You can get 50% reduction in pain intensity. There's no good quality evidence of this in patients with chronic pain, but I can certainly share my 30 years of experiences. Once the patient starts sleeping, everything starts getting better. So how do you get them to sleep? I'm going to jump to the right of the slide here and say sedative hypnotics are not the choice in chronic pain. In an acute setting, they may be appropriate. In a chronic pain setting, they are actually described in every evidence-based guideline, including the CDC summation of current evidence-based guidelines for management of sleep, excludes benzodiazepines. And the question is often asked by our trainees. We don't have any medical students with us here today. They're at Children's. But the comment is every month, why, Dr. Taubin, if you say we shouldn't give benzos and opioids concurrently at the patient with chronic pain, why is every single patient who is referred to the pain clinic on that combination? And my glib answer is that's why they're coming to the pain clinic, because 5 to 7 years of treatment has led to worsened outcomes. So if you need them, it's I would look to a psychiatrist to help support that, or an immediate short-term solution. But once you get out to 4 weeks, you have a secondary problem associated with management of your chronic pain patient, and you are not going to be able to get them off. Staying on the right side of that slide, non-benzodiazepines, complicated. We have incomplete evidence of their role in chronic pain. They've not been well studied. They do target the GABA receptor like the benzodiazepines. They are associated with amnesia and parasomnic events such as sleepwalking, sleep eating, sleep driving, sleep burning your house down. I've heard all of those. And in combination with opioids do not make a whole lot of sense to prescribe another sedative drug without any analgesic benefits. Perhaps improvement of sleep may be a role. So what do you use? After all, don't use these. I use tricyclics as my first go-to drug. I'll spend a little more time on the rationale. They have a multi-purpose response. They're analgesics. Most of them, if not all, the tricyclics are sedatives. And the quality of sleep, though there is some debate, as Dr. Robinson points out to me regularly, in the published literature on what they do to REM and what REM sleep prolongation or delay has to do with pain intensity management. At this point, they are the standard recommendations currently for managing sleep in patients. And I did not include gabapentinoids on this. I should update this slide because there's increasing evidence that there may be a value to using gabapentinoids, gabapentin in particular, because they don't work on the GABA receptor. That's unlike the benzos and the Z drugs. But the gabapentinoids may play a role in improving sleep quality. And there's no significant dependency. I'm mentioning melatonin, cheap, safe, 1 milligram to maximum 8. I used to advise people a few hours before. The latest advice I heard was 6 hours in advance, which is interesting, which was contrary to my usual practice. And there is actually literature to support this 6 hours in advance introduction of melatonin. Remeltion is available on prescription. Good luck getting it approved. I've written 5 authorizations and I still can't get it approved. But if the person is wealthy or has an unbelievable Cadillac insurance, they may be able to get it. It basically is a melatonin analog. M1, M2 receptors are activated, and it basically is an expensive way of delivering melatonin. But that may, as a safe alternative, to certainly to the benzos. A word on acetaminophen. Effective. Issues with acetaminophen are dose. Dose. There's no evidence that I'm aware of to evaluate acetaminophen in long-term trials for pain relief, although certainly its wide use is demonstrated that it has at least the popular experience of pain relief. It is a problem if you add over-the-counter acetaminophen to any acetaminophen that you may be prescribing, and don't forget you're prescribing acetaminophen if you're giving them Tylenol 3 or hydrocodone or oxycodone in combination. So an individual under 60 years old without alcohol history, and that means they drink at all. So the alcohol history we know is really reliable. They really tell us exactly what they're drinking. So if a patient tells me they use alcohol, I consider them at risk for acetaminophen toxicity, and I drop it to 2 gram a day limit. And that also applies to age. Current recommendations are over 60. The 2 gram limit applies. Acetaminophen inadvertent liver failure is intermittently tied with hepatitis C as the number 1 cause for liver failure, leading to liver transplantation. So it is a serious drug and needs to be treated seriously. In combination with NSAIDs, contrary to popular opinion, including my own understanding until I began reviewing this in detail, there is combined adverse renal effect. So patients on therapeutic dose NSAIDs, when you add an acetaminophen, you're increasing the renal toxicity issues that are associated with that NSAID. So it's about dose, and pay attention to it. NSAIDs, the number 1 drug used for pain in the world. It's also the number 1 drug category associated with adverse drug effects. Of all adverse drug effects published, 25% are NSAID related. So these two are not without their toxicity. There's no demonstrated significant difference in analgesic efficacy in any literature that I've reviewed between one NSAID or another, and this includes going to COX-2 selective drugs versus non-selective cyclooxygenase drugs. So the expensive celecoxib offers no therapeutic advantage for analgesia than the inexpensive over-the-counter naproxen or ibuprofen alternatives. All NSAIDs interfere with cyclooxygenase type 2. So what your goal is when you go to selectivity is to avoid cyclooxygenase type 1. Why? Because cyclooxygenase type 1 interferes with platelets. That is the most significant difference between selective and non-selective NSAIDs. There is minimal, if any, interference with platelet aggregation with the cyclooxygenase type 2 drugs, and therefore worth considering. The hope that it would alleviate the big concern about gastrointestinal toxicity is lessened, but you still have some advantage. Some data from the GI literature on asymptomatic patients on COX-1 and COX-2 agents finds that there is about a 50% lessened incidence in asymptomatic duodenitis and gastritis. So this is visible evidence of irritation of the gastric or duodenal mucosa seen in 10% is a round number, I say, in cyclooxygenase type 2. So that's 10% incidence, which is better than the almost 20% incidence, but it is not zero incidence. So you're still going to bang into trouble with these drugs. I've listed selectivity, just sort of common drugs that you may encounter. You can see celecoxib as a highly selective drug. Diclofenac, very, very popular drug, popular because it doesn't cause GI upset. Interestingly, in peer-reviewed pharmacology journals, Jim, I must say I've reviewed this, some say it is non-selective, some say it is semi-selective, and some say it is selective. So obviously our pharmacology published experts are in disagreement. I would consider it a highly selective drug because when you raise the diclofenac dose up to its maximum, it has the exact same side effect profile of celecoxib, including increased cardiovascular risks that are frankly associated with all the NSAIDs, but we've been getting away with prescribing celecoxib at very, very high doses because of its GI tolerance and the lack of bleeding concerns. And if you dose celecoxib down at 200 milligrams a day, it's about as adverse as over-the-counter naproxen on cardiovascular risks. So I don't think there's a magical cardiovascular toxicity with COX-2. I do not have evidence to support that. That's my caveat. But at this point, there's no literature to say that you get a free ride with naproxen at full dose either. It's just if you gave someone 3 to 5 grams of naproxen a day, they are going to have cardiovascular risks associated with that. One more word on the NSAIDs, since they're so popular, we prescribe them like candy. Patients take them like candy. Is that they have a clear interaction with all antihypertensive drugs. So if you have a patient as a primary care provider struggling with blood pressure control, we ask about stress, we ask about alcohol, ask about over-the-counter NSAIDs, and look at your own prescription list, because the elimination of an NSAID off a patient with poorly controlled hypertension will reduce, in my experience, it's a small N, but the literature supports this as well, will reduce the blood pressure systolic by 10 to 15 points. So before adding second and third and fourth line antihypertensives, stop the NSAID because you're going to improve blood pressure. Corticosteroids, just 30 seconds on it. They're anti-inflammatories. They're useful for disc and spinal injuries associated with radiculopathy. You can inject it in the epidural space or transforaminal space. You can give it orally. You get about the same blood levels. And we have no studies to compare oral steroids with injectable corticosteroids in terms of benefit. The data, frankly, on injectable epidural steroids is weak enough that many, and I think it's weak enough because we, in the scientific field, have not studied it in the correct population, because it really does work in selected patients. But if you take a bunch of patients who are not screened, done differently, not dosed right, and not understanding the pathology, you're going to get junk data, and the data is not strong even in injection. but it is a great anti-inflammatory. Glucose intolerance, significant, even in the epidural space. We interviewed a patient this week with the students, and this guy had just had an epidural. He was a diabetic, and he said he had pretty good relief. He thought it helped. He wasn't so sure. I said, what happened to your blood sugar? I was expecting this response. He said, oh, yeah, it went up to 400 for the next 10 days before it came down. So warn your patients and think about your diabetics, whether it's worth the marginal benefit before you blast them with corticosteroids. All right, tricyclics. My favorite drug, my nickname is Dr. Nortriptyline, and I'm going to explain why. Because they are the principal neurotransmitters in the descending inhibitory pathways, which is our endogenous pain control system. They work at multiple levels. They work, of course, in the brain in our depressed patients, in the cortical and limbic brain, but they're also highly active in the periaqueductal gray, highly active in the rostroventral medulla, which is highly neuroadrenergic, and also active in the spinal column in the dorsal horn. So when your patients say, I don't want to take those drugs because they're antidepressants, my answer is, well, I'm giving it to you because it works in your spine and in your brainstem, and the side effects are that you'll sleep better and, your mood may be better. But I'm using it as a primary analgesic because that is, in my view, its primary role in pain. Syndromes that are associated with descending inhibitory control is more than just the spine. As you can see, irritable bowel syndrome, fibromyalgia, again, nonspecific low back pain. Your patients who've had adverse childhood experiences, having been sexually assaulted, witnessing violence, having an alcoholic family member at home, these individuals clearly have abnormal inhibitory control and are a high risk for poor outcomes in any pain treatment. The DINIC system is active during menstrual cycle and childbirth, very, very high levels of inhibitory control associated with the delivery of a child. I think it has allowed the perpetuation of the species, that women will do it again and have more babies because the descending inhibitory pathway is robust. Sleep deprivation, patients who are pain catastrophizers, and notably hypnosis has been demonstrated to improve the descending inhibitory pathways. Some mechanisms that may account for why these systems are so robust. Variety of clinical evidence supports the tricyclic drugs, and I'm going to speak to them before I get to the other antidepressants. You can see numbers needed to treat. So this is how many patients have to be exposed to this treatment to have a 30% reduction in their pain intensity. Doesn't speak to sleep, doesn't speak to mood or quality of life, but just pain intensity alone. About 1 out of 2 to 1 out of 2.5 post-herpetic neuralgia. Diabetic peripheral neuropathy, very impressive data. Almost 1 out of 1 to 1 out of 2. So almost every one of your patients is going to have a 30% reduction. Fibromyalgia and central pain, the number got cut off. The number is 1.75 in fibromyalgia. So your patients who are not responding to SSRIs who are struggling with fibromyalgia, think of another alternative because it requires the norepinephrine in this drug. You can see evidence that isn't quality enough to meet the high standards of Cochrane, but they do include osteoarthritis, nonspecific back pain. Actually, there is evidence now for chronic pelvic pain in the urological and gynecological literature for substantially improving the pain intensity, function, and long-term outcome. Headache management, and somewhat less compelling evidence in polyneuropathies, post-HIV neuropathy, and post-op breast cancer, but those patients also would benefit from sleep improvement and mood improvement as well. Looking at the other drugs on the left are the serotonin norepinephrine reuptake inhibitors. You see the drugs listed there. They've been demonstrated to be effective to about the same degree as the tricyclics in diabetic neuropathy and about the same degree in fibromyalgia. They don't help sleep. So they only get 2 of the 3. Help mood, help pain, but don't help the sleep component. The SSRIs in diabetic neuropathy, the numbers needed to treat, 5 to 15, is equivalent to the numbers needed to harm in the dropout rate from patients taking that. So it's unclear whether SSRIs play a role at all in diabetic neuropathy. And a reasonable number of fibromyalgia studies have looked at these drugs and have found really no significant benefit for management of pain. Again, it will help mood, And when mood's better, sleep may be better, but the effect is much more indirect. This is a cartoon I put together that gives you a quick summary of what drugs do I pick if I want to get a lot of norepinephrine or noradrenaline there. You can see at the top are the drugs most noradrenergic. Naprotoline, which is a pure noradrenergic reuptake inhibitor. Bupropion, Wellbutrin, no studies on either of those drugs. Yet one would expect on a theoretical grounds that they would be effective. And personally, in my experience, I use naprotoline regularly because I don't fool with serotonin at all and can add that to a patient on serotonergic drugs. Imipramine, amitriptyline, doxepin, dizipramine, nortriptyline, those are the common ones that you, if you're not familiar with now, gain some familiarity with them because they are the best studied and the agents I've been referring to. You can see in the SNRI category, I've given the norepinephrine to serotonin ratios there for you. So you can see milnacipran, which has been released in the United States for fibromyalgia based on its similar efficacy tricyclics, has a ratio of 3 to 1 norepinephrine to serotonin, which is about equivalent to the tricyclics. I don't know if you can find any insurer who will pay for milnacipran, that's Savella at this point. It's a tier 3 drug. Those 3 drugs have a 30% incidence of nausea. So if you're encountering nausea, that's the drug, and they don't help sleep. Again, why I still favor the tricyclics, and you can see on the bottom, most importantly, trazodone listed there as well as typically serotonergic, will help sleep, as we all know, but again has no analgesic relief. A few words on antidepressant side effects. We're, of course, worried about existing cardiac disease. They do prolong QT by a very significant effect in patients who are on other QT prolonging drugs or have a disorder, a cardiac disorder that's associated with abnormalities of the sinus node. So if your patient has atrial fib flutter, has an arrhythmia on an anticonvulsant drug, do not use a tricyclic antidepressant drug. That would be my only contraindication. We all know dry mouth, urinary retention, constipation. So an individual with BPH, a man who is already having difficulty with BPH, you can send him to the ED for a cath for complete obstruction if you're not careful. Again, a significant concern. All the antihistaminic drugs, including over-the-counter antihistaminics that are common in sleep drugs, will generate some weight gain consideration, but the drugs that are more antihistaminic will help our patients sleep, again, avoiding the concerns that are associated with the benzos. They do block the alpha-1 receptor, and therefore patients will be orthostatic, so elderly patients who are likely to tip over when they stand, or if a patient's on other alpha drugs like Xanaflex or tizanidine, you can increase the influence of your orthostatic hypotension as well. Serotonin syndrome, an issue. It's rare to see it full-blown. I've never seen it full-blown. It's common to see it on your patients on serotonergic drugs that get piled on. That would be sertraline, for instance, trazodone to help them sleep, and then they're given tramadol, which is an SNRI with a little mu-opiate effect, and those patients will come in sweaty, hot, tachycardic, and that's because you've given them mild serotonin syndrome. Caution your patient about mania. And be alert to it, and everyone now deserves a warning. I say if you think of killing yourself or someone else, stop the drug, call the crisis line, call 911, call our clinic, and don't continue it. Again, it's not clearly associated with increased suicide attempts that goes along with being severely depressed, but yet it's still a warning, and you do need to include that in your warnings to your patients. Benzos, don't use. Enough said. You've got the slide about why, and I've already mentioned it. It's just not an appropriate drug. And I got to compliment those from Washington State. Newest data is Washington State is number 49 of 50 in benzodiazepine use in patients with pain on the last survey. So we've done a good job in this state reducing that. But I think they all come to the UW clinic because we see everyone on benzos and in combination opioids. Muscle spasm drugs. I consider them useless in chronic pain. They're basically sedatives. No strong evidence of any effect in chronic pain. They basically grandfathered. I just lost my slides. They basically grandfathered into the use of on the pharmacopoeia of anti-pain drugs that are available, so would certainly not proceed with using the anti-spasm drugs long term. They are basically sedatives. There are two anti-spasticity drugs, baclofen for upper motor neuron disease associated with hyperreflexia. That's the evidence. And tizanidine, they work by different mechanisms. They can be combined. And in patients who have spasticity, that's painful, they are appropriate. Multiple sclerosis, spinal cord injuries, and the like. Soma, strike from your medical records any opportunity for you to prescribe carisoprodol. It metabolizes to meprobamate, which was withdrawn from the market due to its lack of benefit and its lethality. And if you withdraw a patient off carisoprodol, they will go into delirium tremens. So be careful as you take your patients off that drug. Anti-epileptic drugs, and I'm running over time. I apologize, but I get to run the show, so Jim, give me an elbow here. I'll be done in 2 minutes here. There's limited evidence for relief in nociceptive pain, although it does appear to reduce post and perioperative hyperalgesia, which means if your patient's going to go in the OR, it's sensible to pre-treat with gabapentin orally and treat post-operatively with gabapentin. That's becoming standard of practice in many institutions. There is evidence to support that, but as an anti-nociceptive pain drug, it doesn't really make any sense. It works on the calcium channels, not on the GABA receptor. I've given the two gabapentinoids, gabapentin and pregabalin. Levetiracetam is also a calcium channel drug. That's Keppra. So that's in the list, different set of side effects, but you can see the list. Significant weight gain, edema, cognitive slowing. So swollen, fat, and slow are the three things you got to worry about with your patients, and it is clearly dose-related in that circumstance. When those don't work, you can get to the trickier drugs. Those are the sodium channel drugs. They're also anti-epileptics. I've listed the common ones on the right. For the sake of time, I won't link the particular side effects, but you can see these are side effects that you have to go to the laboratory to assess. So a patient who's edematous has gained 20 pounds and tells you they're not thinking clearly, you don't have to go to the lab. There's not complicated monitoring. But these drugs, carbamazepine, oxcarbazepine, etc., they have their own set of particular side effects. The evidence-based support for pain relief in these drugs is scant. There's not been many clinical trials. Carbamazepine, oxcarbazepine have been in standard pain pharmacopoeia for years. Not a lot of quality of evidence. Lamotrigine has some, and topiramate only in headache, although many of us will try it for other conditions because we don't know what else to do. Their efficacy in neuropathy, you can see the data on doses you need for pregabalin, for Lyrica, 600 milligrams. That's a whopping Lyrica dose. If you know, you rarely get patients up to 600. Numbers you need to treat is 1 out of 4 for peripheral neuropathy diabetes. Numbers you need to treat with a TCA is 1 to 1.5. That's why I go to TCAs first. The literature offers you the option of picking a gabapentinoid or a TCA for diabetic peripheral neuropathy. In fibromyalgia, again, you have to get to pretty substantial doses in order to get 30% relief in pain intensity using these drugs, although they are effective, certainly. We're going to have a separate talk on cannabinoids. Let me put it this way. They work. They work well in the one good trial that Dr. Robinson pointed out to me, but there is a literature that supports their use in predominantly neuropathic pain and multiple sclerosis, but it is a complicated drug, and we'll probably talk about it later today in one of our patients. So quick summary, non-opioid effectiveness is about equal to opioid effectiveness in non-cancer pain, but certainly with lower risk, lower monitoring concerns, lower cost. Tricyclics seem to be most effective for neuropathic pain. The published evidence is fibromyalgia, diabetic peripheral neuropathy, and headache for non-opioid effectiveness. There are limited but still randomized controlled trials for the non-gabapentinoids. There's limited evidence of the anti-epileptics and antidepressants in nociceptive pain. Side effects are still common, and you still have to follow these drugs and take them seriously. So over time, let's jump into One quick question.